It's a pleasure for me to talk to you today about the role of ADCs in breast cancer and how this actually changed a lot the therapy landscape for our patients. So these are my disclosures. Just to be simple in the beginning, to explain ADCs, how are they structured, how do they really work? And as you can see here, they do have what our goal is to get the cytotoxic payload into the tumor cell to be able to damage the DNA and destroy the cell. So what we need is an antibody, a monoclonal antibody binding to it via a linker. And what actually happens then is that they get internalized and degraded with the lysosomes, and actually then the cytotoxic drug binds to the intracellular target and leads to the cell death of the tumor. And as Professor Wimberg already said, the bystander effect is the one which is most important in that structure, in that mechanism, because what we do know is that not every ADC needs to bind to a receptor on the tumor cell.
So much for the invitation and the kind introduction. You already heard a lot about the use of ADCs in gynecological malignancies, and I want to give you a brief insight into the current and future areas of application in other solid tumors. These are my disclosures. You already have been demonstrated the structure of ADCs, so I'm gonna skip that. We know that the mode of action is basically mimicking some Trojan horse method. So we're using the monoclonal antibody to deliver high doses of chemotherapy directly to the tumor cell and also to the tumor microenvironment, making it a perfect treatment. ADCs have evolved over the time. We started in 1975 with the development of hybridoma technology and continued with the development of monoclonal antibodies in 1988. And from the 2000s on, there were several ADCs approved for different malignancies.